sometimes it is very temptative. Sometimes your ego comes for doing such case of cataract. And unfortunately, nowadays, the safety and efficacy and the reproducibility, the magic word which is the reproducibility, is expected because patients has very high expectation in these days. In the 70s, we were operating hand motion. Patient with coming just for with a vision of hand motion, and the 80s counting finger. In the 90s, we started operating patients with vision 0.1, 0.2 because the phaco have improved. And in 2020, we are operating patients with 20/20 visions. And that's the problem, because patients have looking forward for having a premium or IOL or presbyopic correction or something like this. In my practice, because I'm a cornea guy, patients has to be filtered, because these kinds of patients, the traditional phaco surgeon who does 40 phaco per day does not want a case like this because it will take some time from him. He is used to make the phaco in 4 or 5 minutes, and that's it. And he's expecting very good vision. Okay, so why don't we do triple procedure, keratoplasty, cataract, and IOL as a start? Sometimes we have to do it as a phaco only because the patient is a single eye. He has a stable corneal opacity. His corneal opacity didn't change much in the last few years. And he have noticed recent deterioration of vision corresponding to the cataract that he has. So if the patient is accepting, and this is my first condition to the patient, do you accept to have a 2-step surgery? And the 2-step surgery, we will do it the cataract, and probably we will need a keratoplasty. If he accepts this condition, okay, we'll go for the cataract surgery. If he does not accept this condition, okay, you are a candidate for triple procedure. And that's it. We cannot negotiate more. So how to prepare ourselves? Well, you have to prepare with every tool that you have. Full dilatation, you have to have your capsular stain because the visualization is poor. Surgery should be done at ease. Don't put the patient in scheduled for phaco in a cornea, opaque cornea, while you have a busy day, because this patient will take more time and he needs more attention, and you should not be in a hurry. You have to take your time with him. And this patient needs a slow motion cataract surgery, slow motion phaco, slow motion maneuvers inside the anterior chamber. And as I said before, you have to sit with your patient, speak with him much, and counsel with him the situation. Of course, you have to have an enhanced reticle illumination, and a small trick that we have learned since residency time, that dark adaptation. If you work in a dark adapted condition, you have slightly more contrast and you are slightly ahead with the surgery visualization. Okay, this is, I'm just apologize for the video. It's unfortunate, the day I was recording this patient, and this is a valuable patient for me, the recording system failed for some reason, and I had to record it from a very primitive type of recording. This patient has several corneal opacity and an old dysmatocele. Okay, so at the first instant, you will say it is dysmatocele, it might rupture inside during surgery. No, there are 2 types of dysmatoceles. A true dysmatocele, which means that you are exposed the dysmatic membrane, and the pre-dysmatic seal. The pre-dysmatic seal is a bulge, tiny bulge of the cornea, but it's covered by part of the stroma and probably the dual layer also, and it is epithelialized. It has epithelium on it. However, the true dysmatocele, it's an emergency case for keratoplasty. This is something else. So this is a pre-dysmatic seal, actually, and you have to, of course, I'm fast forwarding the surgery, but all steps of phaco are done in a slow motion, and you have to take your time. And between one maneuver and other maneuver, you have to put some viscoelastic on the cornea to improve the irregularity and visualization. At the end, you will get win. You will win the situation at the final. If you are sure of the guidelines that we have spoke about, that the patient has recently deteriorated and he's accepting he might enter for a keratoplasty, I think it will work. It will work and he returns back to his visual aid. I advise everybody to implant under saline, don't implant under missile in a case like this, because you want to save some steps. You want to make it more easier. You don't want to engage with the viscoelastic and later on you have to remove the viscoelastic. This is another case with the hazy stromal haze, and this is a Francois dystrophy, and it's very rare in Egypt. Actually, we don't have a lot of Francois in Egypt. It's a kind of stromal haze a diffuse haze in the stroma, and we embed here the help of the vitreoretinal illumination, and it helps during the surgery. And if you are lucky enough to have a slit lamp inside your microscope, it might be of benefit, because the major step in cases like this is how to get to make a proper rhexis. If you succeed to make a proper rhexis as a primary step, in a case like this, you have won the case and you don't have a problem in the rest. Actually, you might change your technique. If you are routinely using the cystotome, you might use it's better to use the capsular rhexis in a case like this, because you want to be sure that you are grabbing the anterior capsule and making a clean, round capsular rhexis. The rest is not of a major importance, but at the end, it is a slow motion cataract surgery, and you have to do it at ease in a day with no busy and no stress for getting the best results. There's an old saying in Egypt, the worst thing is to have sight but no vision. And this is what we are doing to our patients. You have to have more appreciation to what is the situation of the whole patient as regards, not only his eye. What is his needs? He needs to return back to what he used to be 5 years ago, so this is the best technique for him. Now, he wants more, and he wants to be more, he has more activities, and he wants to improve his best corrected visual acuity. This is not his technique. At the end, I would like to invite you all, because we will have our national meeting in Egypt, the